Welcome to the Interventional Endoscopy Podcast, Endobariatrics 2.0, balloons, sleeves, metabolic therapy, and the hybrid frontier. Welcome back to the Interventional Endoscopy Podcast. I'm your host, Mankubal Sachdev. Today, I'm going to dive deep on endobariatrics in 2026, what's clinically real, what's emerging, and how to stand up a program that actually works. We'll cover intragastric balloons, the 4 flavors of ESG, revisional therapy with TOR and bars, metabolic duodenal interventions, including Revita DMR and the Reveal 1 results, as well as Aquamedical's radiofrequency vapor ablation with a fresh FDA IDE. We'll look at the hybrid bypass-like frontier and Boston Scientific's Endura program layer, and a practical look at codes, costs, and coverage. Roadmap today, we're going to go a little bit over taxonomy. We'll talk about intragastric balloons, the ESG family, revisional TOR, metabolic and duodenal procedures like Revita and Aquamedical. We'll talk about hybrid bypass-like devices, 4-pass sleeve lineage, building a service, how BSC's Endura plays a role in there, and constant reimbursement and where we're headed. So I'm going to spend a few minutes talking about the taxonomy first. So when we talk about endobariatric endoscopy, that spans, how I measure it, spans 5 therapeutic buckets. The first is space occupying. That includes your intragastric balloons. Then you have restrictive or remodeling, which is your ESG or endoscopic sleeves and your ESG adjacent platforms. Then you have revisional, TOR and bars for post-bypass issue. And then metabolic/duodenal interventions that target the foregut signaling, such as DMR and radiofrequency, as well as steam ablation, excuse me. And then we're going to talk about hybrid or bypass-like, which are multi-component incision-less bypass concepts. And then we'll talk about program infrastructure, training, patient education, and coding and coverage. That's another layer of verbiage that we need to understand. So when we talk about intragastric balloons, the concept is that you're creating a temporary occupancy within the stomach, which leads to earlier satiety. And it works really well with a structured lifestyle program. There's a couple systems out there. There's the Orbera or Orbera 365 owned by Apollo, which is now owned by Boston Scientific. The SPATS 3, Allurion, which is a swallowable, no endoscopy in, but it's only really available outside the United States right now. And then the outcomes show that with contemporary meta-analyses and multi-center real-world data, it typically shows a 10 to 13% total body weight loss, and that's at 12 months. There was a multi-center cohort with Orbera that showed a 12% total body weight loss at 1 year, with 7% early removal for intolerance. Very infrequent serious adverse infections or adverse effects, and those were more consistent with migration deflation, but they were very rare. The economics in the United States is that this is largely a cash pay program. Placement and removal have CPTs, and they're done through endoscopy, but plans often deem the therapy non-covered, so patients have to pay for it. In my experience, and we tried to start this program about 5 or 7 years ago in our office, and this was well before the Boston Scientific acquisition. It was hard because patients were, with the way we calculated it, it was about $7,000, maybe $6,500. And if you think about it, you have 2 endoscopies. So, when you talk about facility fees, which are generally around $500 at a Medicare rate, that's $1,000 for in and out. But then you have to pay for anesthesia, which is roughly about $500, another 1,000. Then you have to pay for any path that you might incur, so you have to incorporate that. So the cash pay procedure for EGD in most ASCs around the United States is somewhere between $1,000 to $1,500. That includes the anesthesia, the procedure, the physician's fee, the facility fee, any pathology you may incur, any extra costs. So when you're talking about $1,000 to $1,500, and let's just go on the high end of that, that's $3,000 to place and remove the balloon. Then the balloon itself would cost about $2,000. And then you have to consider any other visits that you're going to do in as a result of the procedure, preoperative, postoperative, and all those things. typically a couple $100 for, when you do CPT coding for clinic visits. So when you put all that in and you try to preserve a little bit of profit for either the physician or the facility, you're talking around $6,500 to $7,500. I've seen facilities charge $10,000 for balloons, but that's more in the hospital-based centers. So we couldn't really convince patients like, hey, pay $7,000 and we'll do this procedure that's going to help you lose 10% of your body weight, when they knew that for $5,000 they could just go across the border to Mexico and get a gastric sleeve. So kind of a little bit of a difficult thing to convince patients to do. And initially, the way that we were asked to quote unquote sell this procedure was very similar to how weight loss surgeons or plastic surgeons do the cosmetic side of their business. And as a gastroenterologist, just not something that I was comfortable doing. So we weren't able to really quote unquote sell it. And that's why I think as we get into it later in this discussion, things like Boston Scientific's program may be helpful because it takes a little bit away from the marketing, the sales portion of this. So anyway, that's intragastric balloons. Now we're talking about endoscopic sleeve gastroplasty. A lot of different ways to do this nowadays. All these routes aim to reduce gastric volume and compliance, and it drives durable satiety. So basically, you're making the stomach smaller through different means, and that's allowing the patient to eat less and to lose weight, obviously. So first, the sutured ESG, and that starts with Overstitch or the next device, currently available by Apollo slash Boston Scientific United States. Currently, the only suturing device that is being used on a routine basis for weight loss surgery, or weight loss endoscopy, I should say. And there are several new ones coming out in the market in the next few months to years. And there may even be a couple that I'm not aware of that are limited markets released that I haven't been had access to yet. But Overstitch has kind of been the gold standard in America right now. The mechanics of this is that you use the Overstitch to perform a series of full thickness sutures along a greater curvature of the stomach. And multiple prospective and comparative studies have shown total body weight loss at 12 to 24 months to be in the mid teens and sometimes even higher. Few adverse events other than, the post procedure discomfort. And there's a faster recovery when compared to laparoscopic sleeve in the eligible BMI ranges. Until recently, there was no code. There's an eligible outpatient C code for ESG now, and then currently the professional side code is going to be 43999, but that's an unlisted code. You have to have robust documentation, letters. But what's I'm seeing now on LinkedIn and in the last few months, many insurance companies have started to cover it, and so it's a big win for the endoscopy side, and it's a big win for patients ultimately. So this is great for patients who need to lose between 10 to 25% of their total body weight, probably closer to the mid-teens as I mentioned earlier. Also, it doesn't prevent, but when that patient is in that sweet spot where surgery might not be the right choice, or maybe they're not heavy enough to get surgery, this would be a great way to actually bridge that gap. Eventually, the goal of the industry and obviously folks who perform this procedure is to replace gastric sleeves or replace invasive surgeries. But we still know that at the moment, the gold standard is going to be laparoscopic sleeves. And endoscopic sleeve gastroplasty has a way to fit in that niche. But ultimately, as techniques get better, I would imagine, and this is just my guess, and please don't rake me over the coals here, but this is my guess that it would replace the surgical component at some point. But today in 2026, that's not the case. The next step is triangulated ESG. So there's a couple of tools out there. Endomina is one of them. This is a device that allows or creates internal triangulation to grasp and approximate tissue from within the stomach. And it's more of a geometry like you would see with a laparoscopic gastric sleeve. It's CE marked in Europe for ESG, US clearance for tissue approximation, but not quite labeled for ESG as far as I know. There are ongoing trials. One of them is called ESTIME or ESTIME. I'm not sure how to pronounce it, ESTIME. And those are looking at refining the outcomes and seeing how can we use this for ESG. There's another really interesting technology out there called Nitty Notes. They're calling theirs EndoZip. What is it? It's a fully automated endoscopic suturing system that standardizes capturing and firing to create plications with less operator dependence. It got an FDA IDE grant for a pivotal US randomized controlled trial. They had up to about 184 patients, and a CE marked that was obtained in November for EU commercialization. Um, Multi-center data in 2025 reported promising 12-month total body weight loss with a quality of life gain. And the target population is largely class 1 and 2 obesity. And for those of you who don't know what that is, class 1 and 2 obesity are classifications based on BMI. Class 1 is a BMI of 30 to 35, and class 2 is 35 to 30 or to 40. Technically 35 to 39.9, but we're not going to split hairs here. So this is really interesting and exciting because it definitely will have a shorter learning curve because it is a standardized procedure and it's automated. The hope is that this becomes ASC friendly at some point. Obviously, we don't know what the cost of this device will be. My guess is it's going to be priced similarly to Overstitch. But currently, Overstitch is, it's difficult to use, but once you get using it, it's not that hard. It's just initially it's a little cumbersome because it's a lot to learn as somebody who's never done it before. Once you do a few of them, you feel more comfortable. But it is a lot of steps, and there's a process and there's a pattern that you have to remember to learn. You also have to learn how to do different suturing patterns. Something that standardizes may even take this out of our hands as interventionalists and put this into the hands of general gastroenterologists. So ultimately, I think that is the goal with the obesity epidemic in America and across the world and the rise of MASH and MASLD. You need to help patients lose weight, but you can't make it overcomplicated. And when you overcomplicate it or when something has a lot of steps, that's going to scare off your quote unquote general gastroenterologist. Your interventionists are the ones who are comfortable with this, but ultimately, the sheer number of patients who need treatment or will need treatment as the country grows, pun intended, um, this is not something that you can only keep in the hand of like 5 people in the city. This is something that's gonna have to get democratized, if you will. And I think something like Nitty Notes or that something along those lines is gonna be helpful to turn that page. Certainly I haven't been privy to seeing next generation of overstitch or triangulation or endometer that kind of stuff. So those are things that can absolutely, this is something that will absolutely push industry to go and develop methods that allow more people to do these procedures. The final i- gastroplasty type device or procedure is endolastic. We talked a little bit to Fritz Haller in one of our episodes, and this is a very very interesting concept. They've had some good success in Egypt. Um, Something that we really need to learn more about and have more data on to see how effective it is. But the concept is that this company, Endolastic, has designed different types of bands. These are the same bands or ligation bands that we use for varices, but they've changed the design of a lot of the rubber bands themselves to allow for more tissue to get captured and to get captured in different ways. So the thought process is you go along the greater curvature and you put a series of bands, probably 18 to 21, if I'm not mistaken. You go along 3 parallel rows in the antrum or in the body of the stomach along the greater curvature, and then you band it. And what that does is it shrinks up the stomach. And by using pressure necrosis, you scar down and make the stomach smaller. A lot of questions about that long term. What does it mean for intestinal metaplasia, pre-gastric cancer, those type of things? What does it mean for, if you have an area of metaplasia that you're not aware of that you bury between scar? Is that a problem? And that same concern obviously exists with any type of ESG when you're not removing that part of the stomach and you're bunching it up. Do you potentially leave that isolated part of the stomach prone to disease? And none of us know the answers to these questions yet. But it's just something that's going to be interesting to watch. The evidence is very early, but obviously, if endolastics does work, it's going to be extremely ASC friendly and it's going to be cheap because bands are not super expensive. Um, so I and all of us probably we're really curious and eagerly awaiting their results to see what that looks like, to see if this is something we'll be doing in the future. After sleeves, we have revisional therapies, and what that is referring to is after a Roux-en-Y bypass, sometimes that gastric pouch becomes large and you need to shorten it, or sometimes the stoma dilates over time. So TOR or TOR-E, T-O-R lowercase e, um, is essentially something that you do with overstitch. Of course, any of the other suturing systems may eventually allow for this as well. And what you're going to do is you're going to go in there to the stoma and you're going to reduce the size to about 6 millimeters to between 6 millimeters to 10 millimeters. You're also going to try to reduce the size of the pouch a little bit to help uh, decrease the satiety of the patient to make them feel um, less hungry. It can also be helpful in people who have dumping syndrome because, or dumping, not dumping syndrome, but dumping due to enlarged GJ or a lax pouch. Ovesco, the company that makes the over the scope clip, has designed a clip, and they've called this procedure bars, but essentially same thing as suturing it, but you use the clip to shorten out the pouch and the stoma size. Very easy to do. I've not actually done it personally, but I've seen it done, and I've seen it done on animations. And if you're familiar with the Ovesco clip, it would not be very challenging. Certainly, other companies are creating over the scope clips right now, and I'm sure it's not a stretch for them to start promoting their over the scope clips to perform bars as well. Um, The OTSC system for Ovesco is CE marked in Europe, and long-term durability versus suture remains to be defined, but they are pretty bullish on this, if you will. Again, with reimbursement for a tour, there is a C code, and the professional code is a 43999, and it's revisional medically necessary. A lot of times you'll want to get prior authorization before you do that. And I mean, if you can, you should do it because then you're kind of not guaranteed, but you're more likely to be paid for this procedure. The next category would be metabolic and duodenal therapy. So Revita or duodenal mucosal resurfacing DMR, made by Fractal Health. It basically uses hydrothermal ablation of a short segment of the duodenum that burns the superficial layer of the mucosa, leads to mucosal regeneration, and somehow that resets the foregut nutrient signaling and it improves insulin sensitivity and hepatic markers in type 2 diabetes and MAFLD phenotypes. We're going to get really deep into Revita in the future here. I actually will have the CEO of Fractal, Dr. Harith Rajagopalan, on the next episode of the Interventional Endoscopist, and he's going to be a guest, and we're going to dive really deep into this at that point. But Revita 2 is a study that had a 24-month follow-up. It showed sustained drop in A1C about 0.8% with improved hepatic biomarkers. No new safety signals in the extension cohort. And there's a new Reveal 1, which is an open label study, 6 months results in prior people who were responders to GLP-1s. When they stopped GLP-1s, enrollees had lost about 24 pounds or 24% of their total body weight on GLP-1s. And then after single Revita and GLP-1 discontinuation, the weight remained stable through 6 months. There was a change of ANC of approximately 0.04%. Um, and there's possibly about a 10% typical regain after you stop GLP-1s. So they're hopeful that this will help to prevent that weight gain from occurring. And early safety data is acceptable at 6 months. It's still out there, but they're getting a lot of traction, a lot of popularity, and it's a really really fascinating technology. Currently, the current iteration of this device does require it to be done in a hospital with fluoroscopy, but ultimately at some point that will probably change once they get a little bit further down the pipeline. Again, we'll talk much more about this and the studies with Dr. Roger Gofallen in a few weeks here. Um, it's CE marked in Europe, and the US is still investigational, but they do have a breakthrough device designation for weight maintenance after GLP-1 discontinuation. Another one which I'm going to talk about is Aqua Medical. I'm going to give a disclaimer here. I have invested in this company, so I have to be a little bit uh, neutral on this, and so I'm just going to state facts that I have. But they're calling their procedure PIMA, proximal intestinal mucosal ablation, via radiofrequency vapor ablation, or RFVA. They have FDA IDE approval as of November 4th, 2025 for Restore 1, which is a US pilot study using PIMA. It's a through the scope catheter designed to deliver circumferential duodenal and jejunal mucosal ablation over 50 to 70 centimeters. Just like fractal, it's incision-less. However, it is fluoroless, and the hope is for it to be more outpatient oriented or outpatient center oriented. They have a breakthrough device designation as well for uncontrolled type 2 diabetes. Essentially, you have a 10.5 French through the scope catheter with a 2.5 centimeter ablation segment that emits heated water vapor or steam that's generated by radio frequency at the tip. And it has positioning discs which allow you to kind of determine where the proximal and distal portions are of the targeted area. And then the concept is that steam would allow for a uniform ablation region. They have done first in human clinical signals. There's an endoscopy video in 2024, single patient case done under general anesthesia, showing using a double channel scope with no adverse effects at 24 hours with a 1 month follow up. There was glycemic improvement in 1 month, and the A1C went from 8.3 to 6.5%. It's a proof of concept only, so it's not ready, but it is something to keep your eye out on, especially if you're going to get into the world of metabolic endoscopy. Next category, we're going to talk about the hybrid or bypass-like devices. So one is called 4Pass, made by a company called Chiron. It combines channeled gastric balloons, which lead to restriction with the transpyloric conduit. That's flow control, and an intestinal sleeve, which is bypass-like. So you give you a restrictive, a flow control, and a bypass-like effect. Preclinical and transitional data support superior weight and metabolic effects versus semaglutide in a head-to-head animal model. Early, but obviously, but very intriguing. There is concerns about anchoring, migration, and retrieval. All those things are yet to be seen. This is extremely early, but just something to keep your eye on. Cautious optimism because prior endoluminal sleeves like Endobarrier and Valentex or Valentx validated that physiology, but they ran into anchoring and hepatic abscess issues. So any modern sleeve must be safely anchored, easy to remove, and you also have to be able not to block the pillow up so much that the patient ends up with hepatic abscess. So these are things that they're investigating. They're not ready yet, but several companies are looking into that. I know Gore acquired a company about 6, 7 years ago, and they have a nitinol balloon with a tail that acts as a sleeve. So that's also something that could come down the pipeline. They haven't really done a lot of work, or at least not publicly available work about it. So I don't know where they are with it. I do know they acquired it, and so I'm not sure what they're going to do with that. Now let's move and shift gears and talk about building a program. So right now, Boston Scientific is the only company that has created a weight loss solution or a program to help you as a clinician create a weight loss program, or endoscopic weight loss program. And that program is called Endura. It's a Endura. Uh, uh, it involves bundling for ESG with the codes or TOR and Obera, and it provides educator training, proctoring, patient education, and then there's a lot of reimbursement toolkits. They provide you the hospital C codes. They give you letters for the 43999 code, and they're hoping to help each individual physician who's trained on weight loss endoscopy to make a successful program. So they'll work with you to talk to your hospital, eventually your ASC when it becomes available. help you get the paperwork you need to get everything approved through the insurance, and work with the hospital, make sure they are reimbursed properly for the cost of the device. So very exciting. First time, obviously it behooves them from a business perspective because they're going to get in there and, your success is their success. But they really are investing a lot of time, effort, and obviously money into creating this program to help physicians grow their weight loss programs. And there's a couple of nice webinars online about it. There's a lot of information on their website. Definitely refer you to that if you have interest in developing your own weight loss program. So let's talk about costs and reimbursement. We kind of touched briefly on this in certain issues, but with ESG, you do have an outpatient C code. Your hospital's going to have to do that, and your professional code is an unlisted code, and you'll need to have letters. But if you start doing prior authorization, commercial coverage is much improved. And as mentioned, several insurers have started to jump on board with this. Over the last 2 to 3 months, there's been a lot of LinkedIn posts and press releases about different insurance companies getting on board. So I think that number is going to start to proliferate over the next year. So keep an eye out on that, and keep your ear to the ground if you're interested. Tor, same thing, a 43999 code. Prior authorization helps quite a bit. Making sure that you're talking about revision in your letters is important. Gastric balloons, typically still a cash pay program. Package services. Unfortunately, not a lot of movement on the coverage with this. And, you wonder though, balloons, you go, you put them in, there's the weight loss, and then you remove it. And if unless the patient fixes their habits, they gain the weight right back. So a sleeve is probably better in some regards because it's lasting, but at least but some patients may not want something permanently changing their anatomy. So the balloon might be a good alternative, especially if the patient's disciplined to where they can use the balloon to learn how to eat again. The question, another question though, is will GLP-1 agonists like Wegovy, etc., will does that make a balloon obsolete? I don't know the answer to that question, but they're both prevent the patient from eating a lot. They both cause a lot of nausea, and you lose a lot of weight with both of them. And when you stop either one, you gain the weight unless you change your habits, which is what really is the challenge with a lot of these patients. For mucosal resurfacing with Revita, it's an add-on code. It's investigational right now, so it's not being reimbursed. There are several studies going on with fractal around the United States right now, and I do believe Aqua is coming. I did not talk a lot about Endogenics, but that's another company that is very similar to Fractal, but they don't use steam or heat like Fractal and Aqua. They use microwaves. It's another catheter. It does require fluoro as well, and you burn the duodenum with this microwave type catheter. I know that it's backed by Mayo, and Mayo is doing some studies on it as well. So that's also in the investigational period. Apologies to anybody from Endogenics who might be listening that I didn't mention it earlier, but certainly it's on the radar as well. Um, and that's the same with the Aqua as well. So where are we headed? I think device and drug combinations are going to become standard. I think you're going to end up getting patients who are obese or have MASL or MASH or other comorbidities secondary to obesity. You're going to end up giving them a GLP-1, and then you're going to try to do a DMR, mucosal resurfacing, or steam ablation, etc., to hopefully maintain weight loss and glycemic control. Um, and for those patients who have a lot of weight to lose, you're going to end up doing either surgery or endobariatric procedures. And then the question becomes, when they have surgery, can you revise them with suturing? And that's the next thing. So TORA procedures and bars are going to be probably pretty normal after a routine gastric bypass. When you talk about gastric sleeves, I don't know that today. Oh, I should say I know that today endoscopic sleeves are not going to replace laparoscopic ones, and there still is going to be a role for surgery. But I think that you're going to see a large rise in endoscopic sleeves as the technology gets, number one, easier and simpler to use and more predictable, and number two, cheaper. Right now, those devices are probably around $2,000. Don't quote me, but it's probably right around that amount. And When that price comes down, then you can start talking about doing those procedures in an ASC. And then finally, you're going to have a hybrid metabolic systems like 4 paths that are going to definitely be a role in the future. So today we map the current endobariatric landscape with balloons, ESG, and 4 different varieties, revisional tour with bars, two distinct metabolic approaches to duodenal resurfacing, as well as a brief mention of endogenics, which is a third one. We didn't talk much about the data, but I just mentioned it briefly on the Reveal study. Um, and we talked about the hybrid frontier. We also talked about Endura being a program scaffold to help clinicians get better reimbursed and to learn more about how to grow their programs. I put a lot of references in the show notes, including links to all these technologies as well as the Endura program. And before I sign off, I just want to remind everybody, number one, mental health. If you're suffering from anything, please seek help, get some counseling, talk to somebody. As I've said over and over again, we all live very stressful lives in endoscopy and in GI. I mean, everybody in the world lives in a stressful environment, but we have certain responsibilities when we're doing procedures and stuff, and lawsuits and things like that that can really affect how we function. So if you're struggling with NK, please get some help. And if you're a young physician or even an old physician, I'm getting into that category slowly. Join your societies, participate. ASG, ACG, AGA, AASLD. If you're a surgeon listening to this, your surgical societies. That's where you can really make an impact. And procedures like this won't be possible unless the societies get behind them and help us get the reimbursement of coding. The companies are starting to do this for themselves as well, but the societies are where that change can really occur. So if you're not involved, get involved, and it's really important. So once again, everybody, thank you for listening to the Interventional Endoscopist. I really appreciate it. If you enjoyed the episode, please drop a like or subscribe, or share it with a friend. And if you have any feedback, please share it with me. Thank you so much. And until next time, this is Makabo Sachdeva signing off from the Interventional Endoscopist.